Welcome. In this lecture, we'll be discussing the different presentations of cortical ischemic stroke. Before discussing these presentations, let's first cover three main things: the lobes and their normal function, the vessels that supply each of these lobes, and what dominance is. We have four basic lobes that make up the cortical functions. The anterior or frontal-most lobe is known as the frontal lobe, seen here in purple. The lateral-most lobe, seen here in orange, is the temporal lobe. The posterior-most lobe, seen here in blue, is the occipital lobe, and the lobe seen in yellow is known as the parietal lobe, which is typically sandwiched between the rest. The frontal lobe controls important functions like movement, speech, decision-making, planning, and personality. It helps you solve problems, control emotions, and focus attention. Simply put, it is your decision-maker or executive function lobe. It also houses the motor cortex, which is important for movement or motor control, typically of the lower extremities, the upper extremities, and of the face. It is also important for sensory input, regulation of different types of emotion, and makes up your personality. Typically, when active, the frontal lobe inhibits and suppresses the primitive reflexes. These are reflexes that individuals typically have when they are infants, such as the Moro or grass reflex. Furthermore, in the posterior lateral-most aspect is something known as Broca's area. This is typically seen in the dominant hemisphere, which we'll talk about in the upcoming slides, and is important for speech production. A way that I help to remind myself of the functions of the frontal lobe is with the mnemonic M-speech, where M stands for motor, S for speech, such as Broca's area, P for personality, the first E for executive function, the second E for motion regulation, C for concentration, and H for higher cognitive function. The next lobe we'll discuss is the lateral-most lobe, seen in orange. The temporal lobe is mainly responsible for hearing, language, memory, and emotional processing. It also contains something known as Meyer's loop. Meyer's loop passes through the temporal lobe and is important in the visual pathway, as it provides information to the occipital lobe and contains vision. It is also important for forming long-term memories, as well as processing different types of emotion. Within the lateral aspect of the temporal lobe is something known as Wernicke's area. This is also typically seen in the dominant hemisphere and is important for understanding and comprehending speech. The next lobe we'll discuss is something known as the parietal lobe, which is responsible for processing sensory information like touch, temperature, pain, as well as spatial recognition. It helps you understand where your body is in space and helps guide hand-eye coordination and allows you to recognize objects by touch. It is also important for doing simple tasks like math, such as addition or subtraction. The last lobe we'll discuss is the occipital lobe, which is mainly responsible for vision, as it contains the primary visual cortex, which processes everything you see, like color, shape, and motion. Now that you understand the primary functions of each of these lobes, understanding how they present when damaged should be a little bit more straightforward. So now let's discuss what blood vessels supply each of these lobes. We have three primary blood vessels that supply the cortex. Seen here on the diagram on the right, we have in yellow the anterior cerebral cortex, in red the middle cerebral cortex, and in blue the posterior cerebral cortex. The anterior cerebral cortex, also known as the ACA, supplies both the frontal and parietal lobe. More particular, it supplies the medial aspects of these lobes. In the second image, seen here on the bottom, the anterior cerebral artery comprises of a right and a left, and you can see that they are going along the medial or middle aspect of both hemispheres. Understanding that it supplies the middle or medial portion is extremely important. In comparison, the MCA, or the middle cerebral artery, supplies the lateral aspects of the parietal and the lateral aspects of the frontal lobe, and almost entirely of the temporal lobe. The last artery is something known as the posterior cerebral artery, which supplies the posterior aspect of the brain, comprising mainly of the occipital lobe. Now, before discussing what happens when each of these are damaged, let's first discuss what dominance is. Simply put, dominance is depicting either right hemisphere or left hemisphere being dominant. This is important to understand because depending on what hemisphere is dominant, your different locations can exist for such things as Broca's area or Wernicke's area, which is always seen in the dominant hemisphere. Now, on exam day, you typically want to look for something known as hand dominance. This suggests that the opposite hemisphere is dominant. Example being, right-handed individual will have a left hemisphere as dominant because the right side of the brain typically supplies the left side of the body, and vice versa. Dominant hemisphere simply is more things are done here. It is important to understand this because usually the dominant area is important for finer touch as well as larger functions, such as Broca's area or Wernicke's area. Now, most people are left hemisphere dominant, aka they are right-handed. But for clinical purposes, roughly 90% of right-handed individuals are left-sided dominant, where only 40 to 50% of left-handed individuals are actually right-sided dominant, making the other 50 to 60% still left hemispheric dominant. This is important to understand for clinical practices and what you might see on the floors, but for the purposes of your exam, understanding this should be sufficient. Now let's talk about the different stroke presentations and what happens when these arteries are damaged. The anterior cerebral artery supplies the medial or middle aspects of the parietal and frontal lobes. It also contains and supplies blood flow to the motor and sensory homunculus. It'll supply to the medial aspects here. So on the right side here is your motor homunculus, and on the left side is your sensory homunculus. The more medial you are, the more likely you are to supply the lower extremities. The more lateral you are, or the outer portion, the more likely you are to supply the upper extremities. This is true for both the motor as well as the sensory homunculus. How I've always liked to remember this is in my head, I take this image and I straighten it out. So I put them straight, just like this, both homunculus straight, just like that. And then what I do is I draw a little stick figure here. Now, this helps to remind me that here is the lateral aspect, and here is the medial aspect. This is just this image down here, straightened out. This has always reminded me that the more lateral aspect does the upper extremities, or the face, and the more medial aspect does the lower extremity. Again, this is just the way that I have taught myself to remember this. And is it helpful for you, then I feel free to use it. Now, how exactly does an ACA stroke present? Well, the good thing about ACA strokes is that they typically present very similar to one another. Now, a right ACA stroke, or a non-dominant hemisphere stroke for the most part, will have the left lower extremity be weak or have sensation changes. Remember, since the ACA supplies the medial or middle aspect, it'll supply the lower extremity more so than the upper or face. This will also have personality changes, lack of motivation, primitive reflexes, urinary incontinence, and executive function issues. All things that we've already established with the normal function, just opposite of it, as it is now damaged. The left ACA, on the other hand, or a dominant side stroke, will have right lower extremity weakness and present very similarly. Thus, sometimes the only thing that you can use to decipher between these two will actually be which side is weaker, the left lower extremity or the right lower extremity. But sometimes they'll give you something known as transcortical aphasia. Transcortical aphasia can be thought of as Broca's or expressive aphasia, but instead it has intact repetition. Broca's aphasia, you cannot repeat anything. In transcortical aphasia, you still have broken speech, but you have intact repetition. You can repeat after an individual. This is sometimes given on exam day to help push you more towards the dominant hemisphere being damaged. Now let's compare this to the middle cerebral artery. This supplies the lateral parietal and frontal lobes, and typically most of the temporal lobes. And it also supplies motor and sensory homunculus. In this case, it's supplying the lateral aspect, so it'll supply the upper extremities, aka the face as well. Now, in a right MCA, or non-dominant side stroke, we're going to have left-sided motor weakness, or contralateral-sided motor weakness, to both the face and the upper extremity. And that's because the MCA supplies that lateral aspect of the homunculi. You'll also have hemi-neglect in the non-dominant area because it is damaging the parietal lobe. If it is the right MCA that damaged, you'll have left-sided hemi-neglect. You completely ignore the left side of your body or of images. You'll also have something known as apraxia deficits. Apraxia is the inability to carry out purposeful movements or tasks, even though you have the strength, coordination, and understanding to do so. So you just cannot carry these out, even though you physically can, you just would not be able to. You also typically have right eye deviation in stroke, especially in MCA stroke. You look towards the damaged side. And you'll have something known as left homogeneous superior quadranopia. This is due to damage of Meyer's loop. And I have an image of what this looks like when we talk about the dominant side. So the dominant side will present very similarly, but it has some high yield differences that you should know. So the left MCA, or dominant side, will have contralateral or right-sided face and upper extremity weakness. Again, you look toward the side of damage, so left eye deviation, and this will have something known as right homogeneous superior quadranopia. This is what that looks like. Only a quadrant is damaged, and that is because it affects Meyer's loop. In some cases, you can actually have full homogeneous hemianopia, but for the board purposes, it is important to know that Meyer's loop will lead to quadrantanopia. So if you damage the left MCA, that'll lead to a right superior quadranopia. You'll also have broken speech, which affects broken speech, or the inability to repeat or write. Remember, you cannot repeat sentences. It is important to understand that this is associated with superior division of MCA. The superior division of MCA, definitely know that for your board purposes. If you have word salad, where you cannot comprehend but can form full sentences, you can have Wernicke's aphasia. So that's where you can talk fine, but you actually make no sense. And this is due to inferior damage. For large strokes, you can have something known as global aphasia, where you damage both these areas. So in this case, you cannot understand and you cannot speak. Understanding this slide for exam day is extremely high yield because MCA is the most common cause of stroke, thus it is the most commonly tested stroke on exam day. Now let's talk about the PCA, or the posterior cerebral artery. This mainly supplies the occipital lobe. Now we have a right PCA and a left PCA. The non-dominant, or right, will lead to left hemianopia with macular sparing, or left hemianopia with macular sparing. The reason being is you get macular sparing is because in PCA strokes, because the macula, or the center of vision, is supplied by both the posterior cerebral artery and partially by the middle cerebral artery. If the PCA is blocked, the MCA can still provide enough blood flow to preserve central vision. Thus, for a right PCA stroke, you're going to have left-sided hemianopia, where for a left PCA stroke, you're going to have right-sided, seen here, right-sided. This will be a dominant, but you have the macular sparing. You can still see out of the center because this is also supplied by the MCA. With the non-dominant stroke, you have something known as topographic disorientation. This is the inability to navigate or orient oneself in familiar or unfamiliar environments, even when vision and memory are otherwise intact. This is seen in a non-dominant stroke. In the dominant side, or the left PCA, you have something known as alexia with agraphia. Alexia with agraphia is the inability to read while the ability to write remains intact. This is also known as pure alexia or pure word blindness. Now, the lesion must be in the dominant occipital lobe, and the reason that this occurs is because writing involves passing info from Broca's to the motor cortex. So that motor function is still intact, but reading involves passing info from the occipital lobe, which in this case is damaged, to the Wernicke's area. Thus, reading is not intact, but writing is. Here is a table demonstrating these unique presentations for completeness sake. Now, let's cover 3 unique presentations that we typically see and are tested on exam day. It should be known that these are very high yield to know for exam day because they like you to test you on the neuroanatomy. Gerstmann syndrome is caused by ischemia in the dominant parietal lobe. This typically presents with 4 things: acalcula, or the inability to do simple math; right-left confusion, which is exactly what it sounds like; finger agnosia, where you cannot identify individual fingers, such as the thumb or the pinky or the index finger; and then agraphia, which is trouble with writing, not secondary to weakness. If you see these 4 things on exam day, be on the lookout for a dominant parietal lobe lesion as your answer choice. You can also have pure motor stroke. This is due to a lacunar infarct. Simply put, lacunar infarcts are strokes that affect the small branches, in particular the lenticular striate of the main arteries of the brain. These are termed lacunar infarcts or small vessel strokes. But a pure motor stroke is a lacunar infarct that affects the posterior limb of the internal capsule. A stroke in the posterior limb of the internal capsule causes a pure motor stroke because it contains tightly packed descending motor fibers from both the cortical spinal and the cortical bulbar tracts. Thus, this will cause complete paralysis to the contralateral side. AKA, if you present with full paralysis on the left side of your body, that is suggestion of damage to the right posterior limb of the internal capsule. Down here is an image of that internal capsule. As you can see, we have an anterior limb and a posterior limb. Damage to this blue structure back here will cause this presentation. And last but not least will be the pure sensory stroke. This is also due to lacunar infarct, but typically of the posterior thalamus. The thalamus is very important for regulating all different types of sensation in the body. In this case, when you damage the posterior thalamus, as we see here, this is the thalamus on imaging, this damages the VPL and VPM nuclei, receiving sensory information from the contralateral body. So this damages both these nuclei, and this can cause complete sensory loss of all types, vibration, sharp pain, dull pain, etc., to the contralateral side. And that concludes this lecture on cortical ischemic stroke presentations.